All right. I think we have a pretty good turnout so far. We have a lot of people joining via Zoom. Um, I just wanted to say that I'm happy that a lot of people are here. I know DPS has some schools that are out today, so it's been a challenging day for a lot of us parents. Um, I wanted to say thank you to everyone who's come in person and also those of you who are attending virtually. It's my great pleasure to introduce Dr. David Badesch. He and I first met about 8 years ago when I first started here on faculty, and we took care of someone who was quite entertaining and funny. And so we got to know each other quite well through that process. So Dr. Badesch is a professor of medicine, Carrie and Megan Hicks Endowed Chair in Pulmonary Hypertension, the director of the Pulmonary Hypertension Program, and interim head of the Division of Pulmonary Sciences and Critical Care Medicine at the University of Colorado. He's collaborated with dedicated clinical scientists and steering committees, both nationally and internationally, for clinical trials and registries conducted in the field of pulmonary hypertension. He has close to 200 publications in multiple very prestigious journals and an H-index of 74. And he has served as the chair of multiple leadership national committees and multiple guidelines. He was awarded the Outstanding Physician Award for PHA in 2002 and multiple other awards. Most recently, he received the American Thoracic Society Public Advisory Roundtable Marin Distinguished Achievement Award in 2015. He's been very well recognized in the field of pulmonary hypertension. I remember when I was moving here from North Carolina, they told me that I needed to look up Dave and talk to him, as well as many of his colleagues, including Todd Bull and other people who are in the audience today. In recognition of his service, he received the Chest Foundation Community Service Award, one of the first two recipients in 1998. And more recently, he assisted in the care of patients with pulmonary hypertension in South Africa, as well as the development of clinical guidelines, a registry, and centers for pulmonary hypertension care there. Dave is very well accomplished, but he's also a really kind person, and he has a great bedside manner. And I always tell our trainees that they should really observe his way of treating patients. So I want to thank him for coming and agreeing to give us a grand rounds today. Thank you so much, Dave.
Thank you, Praditi. Thank you for the invitation to be here, and thanks for that very kind introduction. I wanted to begin actually by thanking you all in the cardiology division for assisting us in the care of our patients. I think that, it's been a wonderful collaborative relationship for many years. I can't believe how patient you are with me when I come in and ask for help reading an echocardiogram or something. Everybody's always willing to jump in and help. We share in the care of these patients with people in the advanced heart failure clinic like Amrut, and with people in the adult congenital heart disease clinic and whatnot. So thanks again for the opportunity to work with you. I've actually, today's talk has kind of got two parts. I'm going to go through the sort of the history and where we are to date in terms of the diagnosis and management of patients with pulmonary hypertension, and then spend the second half of the talk providing an example of a novel approach to treating the disease, one that's not yet approved by the FDA, but under study. And it's just a kind of an example of things that are ongoing now in the field. It's continued to be a very exciting field. These are my commercial disclosures. And so you all know most of this introductory part, but and I'll go through it quickly, but pulmonary hypertension presents in sort of a non-specific way, and it's often confused with other diagnoses. The prognosis is quite poor without therapy, and unfortunately, it still requires on average over a year for the diagnosis to be properly made. It requires a methodical evaluation, including right heart catheterization, and the therapies have been evolving, resulting in an improved prognosis, but one that's not yet normal. And as you're going to see over the next 15 or 20 minutes or so, there are now 14 therapies that are approved by the FDA, and that has occurred over the last 25 years or so, so pretty rapid development for a relatively small area in medicine. These therapies have significantly impacted our patients. I'll begin to, I guess, by telling you that one of the things that I say to people when they're considering joining our team and whatnot is it's an area where you can have considerable impact. When I began doing this, which is now some 30 years ago or so, patients came in having been told that they better get their affairs in order. They had on average less than 3 years to live based on data from the NIH registry, and there was very little that could be done for them. They were often listed for lung transplantation almost immediately after presenting and whatnot. And now the fun of it all is that I get to see some of those folks back like 25 years later. And not only have they outlived their anticipated survival, but their children have grown up. They sometimes bring their kids back into the clinic. And what's even more amazing to me is that some of them have begun to have grandchildren. And so it's a huge change over those last 25 or 30 years from a very, very limited survival to now they do come back 25 or 30 years into the course of their illness. And so the illness does tend to be progressive, though, and it's a vasculopathy where the vascular lumen is narrowed over time by thickening of the vascular wall. And in association with that, we see a rise in pulmonary artery pressure and pulmonary vascular resistance. This is due to intimal thickening or endothelial cell proliferation, smooth muscle proliferation, and adventitial thickening as well. And as they reach the later stages of the disease, actually some of the vessels become completely obliterated, and the cardiac output begins to fall off. And in association with that, actually the most severe patients often demonstrate a fall in their pulmonary artery pressure late in the course of the disease as the right ventricle dilates and loses its ability to contract normally and ultimately fails. So the next couple of slides here pertain to the definition of the disease itself, which is actually evolving, and in a way that I think Todd Bull and I would tell you we're not completely enamored with. But the definition of pulmonary hypertension has been a mean pulmonary artery pressure of greater than 25 millimeters of mercury for many years. There have been a group of people in the field that have felt that the evidence warrants lowering that threshold to 20 millimeters of mercury. And that's resulted in a number of patients that I think Todd and I would both tell you probably don't have clinically important disease now being defined as having pulmonary hypertension. It also is not, it makes treatment decisions quite difficult. Some patients will come in kind of expecting therapy to be prescribed if their mean pulmonary artery pressure is greater than 20 millimeters of mercury. And virtually all of the clinical studies done to date, the clinical trials, were done using a threshold of 25 millimeters of mercury or greater. And then it's even more challenging here in Denver because we function at an altitude, 5,000 feet above sea level, where normal pulmonary artery pressures may be a bit higher. So this new definition actually creates some challenges for us. But in any event, precapillary pulmonary hypertension is defined as having a wedge pressure of less than 15 millimeters of mercury and a pulmonary vascular resistance of greater than or equal to 3 Wood units. Isolated postcapillary pulmonary hypertension, which you all see all the time, is associated with an elevated wedge pressure greater than 15. Some people would argue that maybe that ought to be greater than 12 millimeters of mercury, and a pulmonary vascular resistance of less than 3 Wood units. And then what we often share in the care of is combined pre and post capillary pulmonary hypertension. These are patients that have both precapillary disease and left heart dysfunction. And so they frequently have a wedge pressure of greater than 15 millimeters of mercury and a pulmonary vascular resistance that's also elevated, that's greater than 3 Wood units. Now, what I just showed you was from the 6th World Symposium that was held in 2018. These guidelines, published by the European Society of Cardiology and the European Respiratory Society, have changed it even further. So you can see here highlighted in orange, they've determined that the pulmonary vascular resistance threshold ought to be 2 Wood units, which is quite low, especially here at our altitude in Denver. The definitions of pre-isolated and then combined pre and post capillary pulmonary hypertension have otherwise remained unchanged. And then they've defined exercise associated pulmonary hypertension as having a mean pulmonary artery pressure over cardiac output slope of greater than 3 millimeters of mercury per liter per minute. So this is the disease classification from that 6th World Symposium in 2018. What our group focuses on is largely group 1 and group 4 pulmonary hypertension. Those are precapillary variants of pulmonary hypertension. So group 1 is pulmonary arterial hypertension, can be idiopathic in etiology or occurring in association with underlying connective tissue disease or congenital heart disease and other disorders. Group 2 pulmonary hypertension is what you all see quite frequently due to left heart disease. It could be due to HFpEF or HFrEF or valvular heart disease. Group 3 pulmonary hypertension is PH that occurs in association with underlying respiratory disorders like COPD, interstitial lung disease, sleep apnea, or others. And then group 4 disease is pulmonary artery obstruction, and in most cases it's due to thromboembolic disease. Group 5 is a group of miscellaneous disorders. And then this recent guideline statement from the ESC and ERS has updated that classification scheme just a little bit. I think that this is kind of in less important ways and probably not worth delving into right now, but the clinical presentation, patients often present with dyspnea or dyspnea on exertion, fatigue, chest pain, edema, syncope, and dizziness. And it's easy to see how this diagnosis might be missed or confused with other diagnoses. Dyspnea being far and away the most common presentation. And so it's not uncommon for patients to come to us having had a prior diagnosis of something like asthma, or other, respiratory or cardiac issues. And despite our best efforts, it's interesting that multiple educational efforts over the years, the time from the development of symptoms to an accurate diagnosis remains over a year, which is frustrating, and I think it impacts the clinical course of many patients. There are a number of things that ought to bring the diagnosis to mind. One is findings on the chest radiograph, things like a prominent proximal pulmonary artery, peripheral pruning of the pulmonary vasculature, or filling in of the retrosternal clear space by enlargement of the right heart. The EKG findings, I don't need to tell this audience, that you see right axis deviation, right atrial enlargement, RVH, and strain. And then the ventilation perfusion lung scan is an extremely important part of the evaluation. We don't want to miss chronic thromboembolic disease as a cause. And I'll tell you, great strides have been made in treating this disease here at University of Colorado by what Todd Bull has instituted over the last several years. We now have a pulmonary thromboendarterectomy program that Todd developed. He's brought in surgeons to do this and developed a very well organized approach to these patients. And just more recently, Todd is bringing balloon pulmonary angioplasty here to the university, working with Kevin Rogers and others here in developing that program. So 2 extremely important programs that are relatively new to the university that enable us to treat this very treatable population with CTEPH. This is on the right as a surgical specimen from a patient that underwent pulmonary thromboendarterectomy, and doesn't take a lot of imagination to understand that removing this material from the pulmonary vascular tree can result in terrific improvement in their hemodynamics and their functional capacity and things. It's perhaps the most dramatic improvement, maybe aside from lung transplant, that we see in any group of patients with pulmonary hypertension. So a huge advance there. This slide, I'm not sure I agree with the exact size of the portions of this pizza pie and whatnot, but I think that the main point is that left heart disease makes up a large proportion of patients with pulmonary hypertension. In fact, worldwide, it's the most common cause of pulmonary hypertension, and it's obviously very, very important that we work with you in the care of these patients. Cardiac catheterization is an extremely important part of the workup. In fact, it's mandatory for most patients. It's necessary to exclude congenital heart disease, to measure the wedge pressure and exclude left-sided cardiac disease, to establish disease severity and prognosis, and then finally to acutely test vasodilator therapy. So this slide, again, most of you are probably very familiar with this, but what we tend to deal with is precapillary pulmonary hypertension occurring on the left side of this slide if it moves from left to right. And that includes patients with pulmonary arterial hypertension, patients that have PH occurring in association with respiratory disease, and CTEPH, or chronic thromboembolic pulmonary hypertension. Again, these patients have a normal wedge pressure and an elevated pulmonary vascular resistance. Toward the right side of this slide are patients with pulmonary venous hypertension with an elevated wedge pressure and a normal pulmonary vascular resistance. Acute vasoreactivity testing, this is done to identify a subgroup, and it's actually a fairly small subgroup of patients that will respond to calcium channel blocker therapy over time. Inhaled nitric oxide is the preferred agent to perform this with, because it's very short acting and its effects are largely localized to the lung circulation. The definition of a favorable response is a decrease in mean pulmonary artery pressure by greater than 10 millimeters of mercury to a mean pressure of less than or equal to 40 millimeters of mercury, and in the setting of an improvement in cardiac output or maintenance of cardiac output. So a fall in PA pressure due to a drop in cardiac output is not considered a favorable response. And again, I'll point out that Todd is working with a resident and biostatistician here, looking at how we actually define pulmonary vasoreactivity and whether or not the response to oxygen needs to be broken out from the response from nitric oxide and whatnot. And I think that an important paper will be forthcoming from that work soon. So it's very important to risk stratify patients to enable us to choose appropriate therapies. And there are a number of different ways in which this is done. This is from the ESC and ERS guidelines document. And you can see if you just look at the red column on the right, that sort of generates a profile of high risk. So patients that have evidence of right heart failure, rapid progression of symptoms, a history of repeated syncope, an advanced functional class like functional class 4, poor performance on the 6-minute walk test, poor performance on CPET testing, or an significantly elevated BNP level tend to have a high risk profile, as do patients with an increased right atrial area, a poor TAPSE or tricuspid annular plane systolic excursion. The presence of a moderate or large pericardial effusion is associated with a poor prognosis. And you can see their elevated right atrial pressure and a reduced cardiac index are also associated with a poor outcome profile or high risk situation. This is another way that we can risk stratify our patients. It's the REVEAL risk calculator or REVEAL risk score. And you can see on the right there that patients that have a higher risk profile or risk score demonstrate a poorer prognosis over time. This is a simplified risk assessment tool using just 3 parameters: the WHO functional class, 6-minute walk distance, and NT-proBNP level, and it breaks patients out into 4 risk strata. So maybe not quite as accurate as some of these more involved risk calculators and things, but it's still helpful clinically. So moving into the treatment of these patients, if a patient is non-vasoreactive and therefore not likely to respond to a calcium channel antagonist, they're then stratified into lower intermediate risk group versus a high risk profile. The low or intermediate risk patients are candidates for oral therapies, and typically today that would be combined oral therapy with an endothelin receptor antagonist and a phosphodiesterase inhibitor, and perhaps ultimately an oral prostacyclin or prostacyclin-like compound. Higher risk patients often get started straight away on a parenteral therapy, most often an intravenous prostacyclin, IV epoprostenol or treprostinil. And then they might even deserve a fairly prompt consideration for lung transplantation, although I'll say that we're able to delay transplantation now in many patients for many years with medical therapy. So there are currently 3 pathways that are considered approved therapeutic targets. Our FDA-approved therapies all fall within one of these 3 pathways: the endothelin pathway, nitric oxide pathway, or prostacyclin pathway. And I'll mention just a little bit more about each as we march through the therapies kind of quickly. I've chosen to show a few papers, usually the first paper leading to a new therapeutic class or a paper leading to an expanded patient population. So this paper, to provide you kind of some historical context, was published in 1996. And it looked at what was then called primary pulmonary hypertension, what we now call idiopathic PAH. And it looked at intravenous epoprostenol therapy versus just background therapy then, which was not a lot. And it did show improvement in cardiopulmonary hemodynamics, improvement in exercise capacity as assessed by the 6-minute walk distance, and interestingly, an improvement in survival. And this is still the go-to therapy for our sickest patients. So this is looking at the use of intravenous epoprostenol in an expanded patient population. The first paper was looking at idiopathic pulmonary arterial hypertension. This expanded the population to those patients with scleroderma spectrum of disease and associated pulmonary hypertension. And again, epoprostenol was shown to be a benefit in terms of hemodynamics and 6-minute walk distance. So the next couple of slides summarize the number of different studies done with prostacyclins or prostacyclin-like agents, including intravenous epoprostenol, IV treprostinil, sub-Q or subcutaneously administered treprostinil, inhaled iloprost, inhaled treprostinil, and then oral treprostinil. Oral selexipag, which is an IP receptor agonist, works like oral prostacyclins, but is not strictly speaking a prostacyclin, and then oral treprostinil. And each of these studies, without going into detail, demonstrated benefit of these various prostacyclin or prostacyclin-like preparations. So the second pathway to be investigated was the endothelin pathway, and I'll back up just a moment and tell you, endothelin is a small peptide hormone that binds to receptors on the surface of smooth muscle cells and causes vasoconstriction and cellular proliferation. There are 2 endothelin receptors, ETA and ETB receptors. And this first agent to be studied was bosentan. It was a combined ETA and ETB receptor antagonist. And so this paper from The Lancet was published in 2001. So now just over 2 decades ago, our first oral therapy for the disease. And this slide breaks out the various studies that have been done with endothelin receptor antagonists. That was the BREATHE-1 study that I just showed you. The early study looked at patients with earlier pulmonary hypertension with bosentan and showed that it is a benefit in patients with functional class 2 disease. And then there were studies, there were 2 studies of ambrisentan, the ARES-1 and ARES-2 studies. And then finally, a study of macitentan, the so-called Seraphim study, a third endothelin receptor antagonist. And I'll say that these newer endothelin receptors, if you can call them newer now, they've been on the market for quite some time, but ambrisentan and macitentan have the advantage that they tend not to be associated with significant hepatotoxicity, which was a potential issue with bosentan. So the third pathway is the nitric oxide pathway. Nitric oxide, as you all know, is generated endogenously from L-arginine. And nitric oxide results in the synthesis of cyclic GMP, which is a pulmonary vasodilator and has anti-proliferative effects in the lung circulation. So there are various ways that we can impact this pathway. The earliest way was with phosphodiesterase inhibitors, which prevent the breakdown of cyclic GMP. And now a little bit more recently at least, we have a stimulator of soluble guanylate cyclase, which can act in a nitric oxide independent manner to generate cyclic GMP and cause vasodilatation and anti-proliferative effects. So this was the first study in this sort of therapeutic class or pathway. It was the so-called Super-1 study of sildenafil. It was published in 2005, so 17 years ago or so. And the study to follow that was actually the so-called first study of oral tadalafil, which also showed benefit in this patient population, both of those studies showing improvement in 6-minute walk distance and other secondary outcome measures. Then we began to think, well, should we be combining therapeutic agents? And so this was one of the earlier studies looking at combined therapy. It was the addition of sildenafil to background epoprostenol therapy. You might think, well, that's a little backwards, but back then we had people on epoprostenol therapy, it being the first therapy to be approved, and we looked at whether or not adding sildenafil to that in this so-called PACES study would be of benefit. And so this was done, it was published in 2008, so 15 years ago or so. And then this was a very important study. It was looking at the upfront combination of ambrisentan and tadalafil, an endothelin receptor antagonist and a phosphodiesterase inhibitor, and it showed that the combination of these two drugs was better than either agent alone. And so that created a new treatment paradigm for us. We have many patients that are on that combination today of ambrisentan and tadalafil. And then I mentioned to you the development of a stimulator of soluble guanylate cyclase. The drug is known as riociguat. And it was studied in two important studies, one initially in pulmonary arterial hypertension, and then another in group 4 patients with CTEPH. And these were patients that had either failed pulmonary thromboendarterectomy, which fortunately is relatively uncommon, or who were not candidates for that procedure. So these were those two studies, the so-called PATENT-1 study in PAH, and then the CHEST-1 study in CTEPH of riociguat. And then this paper expanded the population of patients that could be treated. Again, it was a study of inhaled treprostinil in patients with interstitial lung disease associated pulmonary hypertension. And I think Todd would tell you that the patients with underlying lung disease are among the most difficult and challenging patients to treat. And it's because our pulmonary vasodilators can worsen, if they're systemically administered, can worsen ventilation perfusion mismatching and can worsen their hypoxemia. And so despite the fact you might see hemodynamic improvement, their overall outcomes might not improve. So it made sense to try an inhaled agent in this patient population, and it was of benefit. I think we're still waiting to see if there's a therapy, and it might very well be an inhaled therapy like inhaled treprostinil that might benefit patients with COPD associated pulmonary hypertension, another important patient population. So that's a summary sort of where we are to date. I know I went through it very rapidly, but it's kind of the diagnosis and management of patients as of 2023 or so. very active investigational efforts that are ongoing now, looking at novel therapies that will hopefully help to advance our treatment of these patients. While patients do much, much better, we're still far from a cure for the disease. And many of them end up still with a suboptimal quality of life. And some of them still have to go on to transplant. It's a smaller population than it used to be, but there are patients that still fail all of our medical therapies. So back in around 2000 or so, there were a couple of studies that identified the cause, or one of the causes, I should say, of heritable pulmonary hypertension. So we've known for many years that there are families in which pulmonary hypertension is propagated. And in around 2000 or so, two groups working simultaneously, one at Vanderbilt and one at Columbia University, discovered that many patients with heritable disease have mutations in the BMP pathway, the bone morphogenic protein receptor pathway. And so these were seminal publications that sort of helped us better understand the pathogenesis of the disease. And they occurred a little over 2 decades ago. And we've not had any therapeutic interventions since then that have been developed and approved that have taken advantage of this knowledge. And so it parallels in many ways what's happened in cystic fibrosis, where the CFTR mutation was identified, and it took perhaps 15, 20 years for therapies to be developed based on the knowledge acquired there. So now there's a greater focus on going, is there a way that we can help to rebalance BMP and TGF beta signaling in a favorable way that will impact our patients? And so to take you through that, kind of the thought process behind this a little bit, and this is just one of the novel therapeutic approaches under development. There are many others, and hopefully this might help open the door to some of those and things. But in addition to looking at BMP signaling, people are looking at PDGF signaling, for example, and at inflammatory pathways and anti-inflammatory interventions and things. So the field is still very, very active, and this is just one example of a novel approach. But if you look on the left of this slide, you see a little schematic of a teeter-totter that suggests that in a normal homeostatic situation, that activin and BMP signaling are well balanced with one another. Activin signaling being pro-proliferative and BMP signaling being anti-proliferative. And so on the left side is a normal pulmonary artery or arteriole, which is thin-walled with a wide open vascular lumen and a low resistance to flow. But with endothelial, smooth muscle, and adventitial proliferation and thickening, that vascular lumen can become quite narrow, as is shown on the right side, and that can lead to a significant rise in pulmonary vascular resistance and additional strain on the right side of the heart. And this isn't the only cause for those vascular changes, but it may be one of the causes, imbalance of activin and BMP signaling, where activin signaling is disproportionately weighted. Pro-proliferative effects in the vascular wall thickens with narrowing of the lumen. This is another schematic showing somewhat the same thing. PAH is thought to be a progressive disease driven by pulmonary vascular remodeling. It's due in part to an imbalance in anti-proliferative and pro-proliferative signaling in these BMPR2 mediated and activin mediated pathways, resulting in hyperproliferation of the vascular wall. So the drug that I'm going to provide as an example today is sotatercept. It was actually, this is repurposing of a drug that was originally developed to treat forms of anemia. And its sister compound, luspatercept, is actually used in that area of medicine now. But sotatercept was designed to bind and trap TGF beta family ligands like activin. And it's a fusion molecule, a fusion protein, consisting of the extracellular domain of the human activin receptor 2A, okay, fused to the FC domain of an IgG1 molecule, okay? So its intent is to bind these pro-proliferative signaling molecules, activins, and help rebalance activin and BMP signaling, as shown here. So the preclinical work with this drug in pulmonary hypertension was done by Paul Yu and his group at Harvard. And he showed that treatment with sotatercept in preclinical experiments improved hemodynamics, right ventricular hypertrophy, right ventricular function, and arteriolar remodeling. And that led to the first clinical study of this drug. It was the so-called PULSAR study. And this was a phase 2 randomized, double-blind, and placebo-controlled clinical trial of sotatercept in patients with functional class 2 and 3 pulmonary arterial hypertension. So they had to have a pulmonary vascular resistance of greater than or equal to 5 Wood units at baseline and a walk distance between 150 and 500 meters, a 6-minute walk distance. And they could be on stable background therapy up to and including triple background therapy, which is our current state-of-the-art treatment of these patients. So the randomized placebo-controlled portion of the study was 24 weeks in duration. Patients were randomized to receive either placebo or one of 2 different doses of sotatercept, either 0.3 or 0.7 milligrams per kilogram, administered subcutaneously by just a subcutaneous injection every 3 weeks. And then there was an open label extension period looking at safety, which was longer in duration, obviously. The primary endpoint for this study was pulmonary vascular resistance. In many of our phase 2 trials, PVR has been considered the primary endpoint of choice. Secondary endpoints included things like 6-minute walk distance and NT-proBNP levels, WHO functional class, and I'll show you some of those things in a moment. So the baseline characteristics here, the patient population was predominantly female, as in many of our studies. You know, for reasons that we don't completely understand today, this is a largely female predominant disease, perhaps 3 to 4 females to every male. And so this population was, along those lines, was about 80% women. They averaged in age in the sort of upper 40s or so. And in terms of diagnostic classification, this included patients with idiopathic disease, heritable disease, connective tissue disease, and corrected congenital shunts. They were in functional classes 2 or 3. And then in terms of background therapy, I've mentioned it included patients up to and including triple background therapy. Actually, to highlight that, there were 53 to 57% of the patients were on triple therapy. So it shows you these were intensively treated patients even prior to entry in this study, which sort of raises the bar, if you will, in terms of how challenging it might be to show a therapeutic benefit on top of triple background therapy. This is the primary endpoint, reduction in pulmonary vascular resistance. And in both treatment arms, the 0.3 and 0.7 milligram per kilogram dosage arms, there was a significant improvement in pulmonary vascular resistance as compared to placebo. That's shown on the left. On the right is the 6-minute walk data. There was actually an improvement in the placebo arm, which is why we have to do placebo-controlled clinical trials. But the sotatercept treated arm demonstrated further improvement in 6-minute walk distance. And this forest plot breaks down by diagnostic subgroup and whatnot, and treatment background and things, the response to therapy. This is for all of these lines are for the sotatercept 0.7 milligram per kilogram dose. And you can see it's broken out by sex and then by diagnostic classification, idiopathic disease, heritable disease, connective tissue disease, associated disease, and then background therapy, background parenteral prostacyclin therapy, functional class, and pulmonary vascular resistance. And so, again, to point out the background therapy in patients receiving triple background therapy, their pulmonary vascular resistance still fell significantly, as did patients receiving background parenteral prostacyclin therapy, patients in both functional classes, and whether or not the pulmonary vascular resistance was above or below 800 dynes. The next slide is for the lower dose arm, the sotatercept 0.3 milligram per kilogram arm. And the responses perhaps are not quite of the same degree and whatnot, but for the most part, most of the responses in each of the subgroups was again in a favorable direction, meaning toward the left of the line of zero there. And again, patients that were on background therapies seemed to respond. So these are additional endpoints. The results were largely concordant across a variety of exploratory endpoints, including NT-proBNP level, right atrial pressure, pulmonary artery pressure. Interestingly enough, cardiac output was little changed by this therapy. And then we can talk about that later if you'd like. And then there were a couple of other endpoints here: WHO functional class improvement and a multi-component improvement endpoint. Functional class trend in the right direction, but it did not achieve statistical significance. This was a relatively small phase 2 trial with 106 patients enrolled. And then the multi-component endpoint was defined by three criteria: WHO functional class improvement or maintenance of a functional class 2 status, a greater than or equal to 30% improvement in NT-proBNP, and a greater than or equal to 30-meter improvement in 6-minute walk distance. And that multi-component improvement endpoint was substantially better in the sotatercept treated patients. So in terms of safety, we're still learning about the safety of this drug. And this is why we do long-term safety-oriented extension studies and whatnot. But we knew going into this that the drug increased hemoglobin levels. I've already mentioned that it was originally developed to treat forms of anemia. We also knew that it could increase systemic blood pressure, which in our patients is often a good thing. They tend to be hypotensive. And we did see rises in hemoglobin levels. It's also known to cause thrombocytopenia, something else that was seen and whatnot. So more to come there. I'll come back to some longer term safety data in just a moment. But then you might be interested in whether or not a drug that is targeting BMP signaling, did we see a more favorable effect in patients that had an underlying genetic mutation in the BMP pathway? And interestingly enough, we did not. It's thought perhaps that the BMP pathway is abnormally functional or whatnot in patients beyond the group with identifiable mutations. So this slide, it's a little bit difficult to read, and I apologize for that, but it looked at 3 different outcome measures: pulmonary vascular resistance, 6-minute walk distance, and NT-proBNP levels. And each pair of lines going across it was, the top line is BMPR2 variant, and the next line is a non-variant. And so looking at the kind of the force plot marching down, you can see that the responses were pretty similar in patients that had BMPR2 variants versus those who did not. And this was one of there were a number of different biomarkers that were looked at. I didn't bring those all today, but this is looking at changes in activin A levels. And you would hope that you might see a decrease in activin A. This demonstrates target engagement, by the drug. And so we did see a decline in activin levels. And then in terms of echocardiography results, not yet published, but hopefully forthcoming, we did see significant improvement from baseline to week 24 in both sotatercept dose groups versus placebo in terms of right ventricular end diastolic area, right ventricular end systolic area, and then right ventricular fractional area change was improved in the higher dose arm, but not significantly in the lower dose arm. So coming back to safety, if you look at the lower right portion of this slide, you can see that there were, as of the data cut at the time this slide was developed, there have been 3 deaths. One had occurred in the placebo-controlled portion of the study. That was in a sotatercept-treated patient who experienced a cardiac arrest, which happens in our patients. And then 2 deaths occurred in the open label extension study. All patients at that point had been transitioned to sotatercept. One of those patients died of progressive pulmonary hypertension, and the other had a brain abscess. So there were 3 deaths as of the time of this data cutoff in the long-term open label extension study in this phase 2 trial. And then we've begun to see telangiectasia, which is a really interesting side effect, I think, vascular abnormalities. And to date, the vast majority of these have been cutaneous. If we started to see internal telangiectasia or internal AVMs, that would obviously be of greater concern. So telangiectasia have been reported in the Pulsar study and its open label extension. And then I'll show you data from the phase 3 Stellar study. And we're also seeing telangiectasia from that study as well. And so they have been identified as an adverse event of special interest in ongoing trials, and they're being closely monitored and investigated. So I'm going to move on now. This was the publication from the open label extension study. It just came out earlier this year. And then there are 3 phase 3 trials currently ongoing: the Hyperion study, the Stellar study, and the Zenith study. The Stellar study has actually been reported out recently and was just published. I'm going to show you that in just a moment. The Hyperion study focused on patients that were relatively recently diagnosed and that had a high-risk clinical profile. The Stellar study was a patient population that reflected pretty closely the previous Pulsar patient population. And the Zenith study is looking at more severely ill patients, functional class 3 and 4 patients with a high risk score. So these are patients at high risk of dying, and looking to see whether or not the drug might have a role as sort of a rescue therapy, if you will, in severely ill patients. So as I mentioned, the Stellar study was just recently published a month or 2 ago, a couple of months ago. Its design was somewhat similar to the design of the Pulsar trial. Patients were randomized 1-to-1 to receive placebo or sotatercept at a starting dose of 0.3, and then they were increased to 0.7 milligrams per kilogram. And the endpoint for this study was 6-minute walk distance, and there were a variety of secondary endpoints, and I'll show you those in a moment. These are the patient characteristics, and they're pretty close to the characteristics of those patients that were enrolled in the Pulsar study in terms of the sex distribution, age range. Background therapy was even perhaps more intensive than what it was in Pulsar. As you might expect, as time goes by, more patients on triple therapy. So just over 60% of the patients were on background triple therapy in this study. This is the primary endpoint, 6-minute walk distance, change from baseline. And you can see that it improved in the sotatercept treated arm versus those that received placebo. This is a summary of the secondary endpoints, and they included this multi-component improvement endpoint that I mentioned earlier, as well as pulmonary vascular resistance, NT-proBNP levels, time to clinical worsening or all-cause death, the French risk score, and then some kind of quality of life or PRO endpoints using the PAH SYMPACT PRO tool. And you can see that down to the last row, each one of these was significantly improved in sotatercept treated patients with the last row being the cognitive and emotional component of the PAH SYMPACT tool, and that did not demonstrate significant improvement. So to show you some of the numbers here, I guess, that went into that table, this is a plot of time to first occurrence of death or non-fatal clinical worsening event, time to clinical worsening. The blue line there is the placebo arm, and the orange line, sotatercept treated. So even in these heavily treated patients, background therapy, you can see what appears to be a difference. This is a summary of safety from the STELLAR study. And you can see that the deaths here, there were 7 deaths in the placebo arm and 2 in the sotatercept arm. Obviously, well, let me show you the breakout here of the treatment emergent adverse events. Bleeding events were more common in the sotatercept treated arm, as were telangiectasias, I mentioned. 14% or so of patients experiencing the development of telangiectasia in the sotatercept treated arm. Increased hemoglobin levels, thrombocytopenia, and an increase in blood pressure. Kind of the things that we had come to expect from prior experience with sotatercept in anemia and trials and whatnot, and then with the PULSAR study and long-term safety data emerging from that. And then epistaxis, more common in the sotatercept arm, again with telangiectasia being more common. So in summary, the STELLAR study was a phase 3 clinical trial of sotatercept, which is an activin signaling inhibitor in adults with PAH, functional classes 2 and 3. And it improved 6-minute walk distance and delivered clinical benefit across a number of different secondary outcome measures, including hemodynamics, disease severity, risk scores, and patient outcomes, with the exception, as I mentioned at the bottom there, I think of the cognitive, let me just check that real quick. It was the cognitive and emotional component. And then sotatercept was generally well treated, well tolerated rather, with adverse events occurring more frequently in the sotatercept arm, including minor bleeding events, telangiectasia, dizziness, increased hemoglobin levels, thrombocytopenia, and increased blood pressure. So it was interesting that third point there, sotatercept reduced the risk of death and non-fatal time to clinical worsening events by 84% versus placebo. So far, hopeful results. We hope that further studies of the drug continue to support its potential use in this patient population. We definitely need long-term safety data, as I've mentioned. And this is, as I've also mentioned, it's an example of one of a number of different novel interventions that are under development currently. And so hopefully more to come there. I want to acknowledge quite a number of people that have contributed. And most importantly, I think the patient participants in all of these clinical trials who've had the courage to participate in these agents. I mean, when you think about people 25 years ago being willing to participate in the trial of an agent that's infused on an infusion pump 24 hours a day, and potentially a lifetime commitment for them. That's quite a commitment for a research participant. And then all of these agents carry potential risk and things. This last agent that I mentioned, I mean, no prior experience clinically in pulmonary hypertension and whatnot. So definitely grateful to patients that are willing to participate in our clinical studies. And then the colleagues on these steering committees and the investigators, our research coordinators, and the various associations have played a major role in the way the course of this disease has gone over time. The Pulmonary Hypertension Association being among the most important, and I think Todd is now the leader of our Scientific Leadership Council for the PHA. the American Thoracic Society Pulmonary Circulation Assembly, the Pulmonary Vascular Research Institute, which is a global organization, research organization looking at pulmonary hypertension, the World Symposium on Pulmonary Hypertension, which is held every 5 years or so. And then to thank my mentors, Bert Groves was a member of the cardiology division here many years ago. He passed away within the last year. He was a member of the faculty here for many years and actually was director of the cath lab. I think he probably taught Todd how to do right heart caths, is it? And a terrific guy. And then Kurt Stenmark, who was my initial research mentor, my colleagues, Todd, Jack Dempsey, James Maloney, Peter Hauntress, Sue Gu, Andrew Yu, and Brian Park. We have just a stellar group of young people coming up from the fellowship and joining the faculty ranks. And then our current fellows are also outstanding. Danny Kalan Hidalgo's here and Shelley Forbes, both of whom are just fantastic. And we've got fortunate to have terrific nurse practitioners with us, Genevieve Body and Sarah Word. And then we have I think this is a group that goes very much under-recognized, but I'm sure Todd would agree, just a wonderful group of clinical nurse navigators and clinical research coordinators. None of this would be possible without these folks. And our administrative team is terrific as well. Lewis does a great job managing the clinic, and Laura helping us with our administrative. Marcy Terrell provides terrific administrative support. And then Bruce Hoskinson is here. Bruce has been helping us on a volunteer basis for the last decade and just does wonderful work helping to support all kinds of activities, but particularly our PH in the Park awareness event and fundraiser. We thank all of you in cardiology and our cardiothoracic surgical colleagues and the folks in IR that help us with our interventional procedures and whatnot. So thank you very much to all of you, and thanks for the opportunity to be here with you today.
We're going to go over time, but a couple minutes for questions.
One person who's walking out too. I failed to thank Matt Cassiano, our pharmacist, who does a spectacular job taking care of our patients. And thank you, Matt. Yeah, sorry.
Okay.
So Dave, you might be one of the only people in this room that's been here longer than I have, going back to the beginning. So the experience with Bert Groves was amazing. But a question for you, my pointed question for you is the use of these newer agents in our patients, particularly the WHO group 2 groups, because when your group consults on our patients, I find it somewhat frustrating sometimes that more often than not, your final conclusion is that they're not a candidate for these agents. And as I look at the groups that were included in many of these trials, certainly our patients were included in them. And the secondary question is, you often cite concern about their hypoxic vasoconstriction being reversed by these agents. And I wonder if that really is a concern. So there's two difficult questions for you.
Great questions, Ed. And I think the first one, whether or not our agents are of help in pulmonary hypertension that occurs in association with left heart disease. The concern there is actually in patients with left heart disease that will precipitate the development of pulmonary edema with pulmonary arterial vasodilators. Now, that being said, this last agent that I have mentioned is thought to perhaps not have very strong, pulmonary vasodilatory effect. It's largely an antiproliferative drug. So if you were going to choose an agent, that, you might be interested in studying and say combined pre and post capillary pulmonary hypertension, maybe that's the sort of drug, it's one that doesn't have acute vasodilatory effects and might not precipitate acute pulmonary edema. And I think that Todd is actually a site investigator here, is that right, on the Cadence study of sotatercept in just that patient population. You want to comment on that? Or yeah.
It's a difficult dilemma, this combined pre and post. I'm trying to figure out how to do that, and there's a number of studies have come out negative. In particular, the PDE5s have been looked at most closely, and they didn't particularly cause harm, at least in a HFpEF patient population, but there wasn't benefit. They didn't hit their primary endpoint, so we're still looking for that. But just as Dave mentioned, so we're going to look at sotatercept in WHO Group 2 PH. The question would be, is the mechanism make sense in that patient population? So is it really a problem of TGF beta and that sort of thing? So I think that'll be, so it might be safe, might not work. I guess, and then we're pretty interested by the SGTL2 data that's coming out. That's sort of I think the next fund look at least in the HFpEF group. So
that was going to be one of my questions. So Dave, I wanted to ask you a little bit about patient-reported outcomes and how you're using the PROs in clinical trials for pulmonary hypertension.
That's a great question, Pratiti. I was going to answer Ed's second question first, though. Sorry. You also ask about patients, I think, with underlying lung disease or hypoxemia, and the concern about making that population worse with systemically administered pulmonary arterial hypertension specific therapies. And that really is a concern too. We're frustrated by that too. We'd love to be able to treat that population, but the risk of worsening ventilation perfusion mismatching in that population is real. We've seen it over and over again clinically. Are there some patients with lung disease that may tolerate our therapies? I'd say there may be, but in our kind of general thinking of do no harm, we have significant reservations about, our therapies in those patient populations, with the exception being inhaled treprostinil. And again, I'll defer to Todd, who participated in that inhaled study of treprostinil and ILD-associated pulmonary hypertension, and then another study in COPD-associated. Todd? So, tough group. Sorry? Yep. So many of our patients have mixed disease. Because they have mixed disease, without the name of that. Don't want them to try the medication. I think that's pretty much all of the questions, but part of it is stuff that costs too much energy. And the treatment is done with another option, there may be I always look at it with how much of this is RV failure, and how much of this is lung. And so I try to make a judgment, taking our therapy, realizing that our studies didn't study this patient population, there are risks, and then I just try to decide if it works with it. And the good news is usually if we get it wrong, we don't die. So if we get it wrong, we might back off again. But doing no harm. Hi, Mike. Did you have a question?
Yeah, hi, Dave. Yeah, I do. Terrific presentation as always. And it's, remarkable to look at the progress that's been made in pulmonary hypertension. And I would like to get your comment on, some of the reasons why the pace has been so rapid in the last 20, 30 years. From my point of view, being involved in drug development in heart failure as well as pulmonary hypertension with ambrisentan, the availability of an endpoint, an approvable endpoint that is reliable and quite efficient in terms of the sample size requirements. The 6-minute walk has really fostered this rapid development to the point where you can do a study in pulmonary hypertension with an N in the low 100s of phase 3 study and bring it in. Whereas in heart failure, 6-minute walk does not work very well. The reasons for that, I'd like to actually get your comment on. But if 6-minute walk would work in heart failure, we'd probably have 30 drugs approved by now. So it's really interesting, the impact essentially that an approvable endpoint can have in a disorder and basically foster the development of effective therapeutics. So I'll stop there and get your comments.
Great thoughts as always, Mike. And definitely agree. We've been fortunate to have a functional endpoint that seems to work well, 6-minute walk distance. Some people think that we need to look at things like time to clinical worsening. That requires a much larger N number, much larger study, and a much longer time to conduct. They're far more involved studies and more complicated. 6-minute walk works well. And then to have a hemodynamic endpoint that helps us in phase 2, the pulmonary vascular resistance, that's helpful as well. But I've got to tell you, we look to other fields where we're still jealous in ways in terms of clinical trial design, of what they can do in, say, HIV, where you can look at, CD4 counts or whatnot and things and get an answer even more quickly and less invasively. But you're right, having an endpoint, that seems to work is extremely important. And then, Mike, I think the kind of fundamental answer to your question too, as you well know, and you were a part of, the ability of people across the field of pulmonary hypertension to work together on these clinical trials has been remarkable and incredibly important. Mike, for those of you who don't know, I'm sure you all are likely very familiar with this, but Mike led a small biotech company named Myogen that developed ambrisentan, which was a major advance in the field. And I don't know, Mike, you might comment. It seems to me like we're fortunate to have a kind of a well-established group of investigators around the world that are willing to work collaboratively with one another in the conduct of these trials, and that's a big advantage too.
Yeah, I would agree. From the point of view of the sponsor, we call this the pulmonary hypertension mafia, of course. But mafias are quite efficient and work well together typically. And this group of investigators is unbelievably great. And you were a big part of that, locally leading it and instrumental initially in getting ambrisentan off the ground, as you and I shared a clinic, as you remember. And I kept picking your brain about various things as we were trying to figure out how to develop ambrisentan. So you played a huge role in this field, is what I want to say.
I certainly enjoyed that. I get to see Mike Gerber every now and then still, and enjoy catching up with him. The two of you really led that effort. It was quite remarkable. But it's time you referred to the pulmonary hypertension mafia. I think that it's interesting. You also can have a group that's too close to one another or too closed, if you will, and whatnot. And we definitely want things, I think that has happened over the last decade or so, but for things to open up. And it's important that we, engage younger people, in these trials and whatnot to secure the future ability to conduct these studies. So it's a good point.
Agree.
But Praditi's question, I think she had to run, but
Yeah, she had to run.
PROs, definitely of increasing importance, and probably in cardiology as well. We're looking at, patients' symptoms and how they feel with treatment interventions and being able to quantify that. This PAH SIMPACT tool, a PRO instrument, was developed in accordance with FDA guidance. Specifically for pulmonary hypertension, we helped to develop that instrument. And so developing tools that can measure, quality of life outcomes for patients, incredibly important. And so it's a great point. And then I guess, Todd mentioned, and unfortunately Natasha left, but Amrit, the SGLT2 inhibitors do seem to be an important development, I think, in group 2 associated, pulmonary hypertension, HFpEF in particular. And it's nice to have something like that does seem to work. What do you think, Amrit? Is that?
Yeah, I mean, they seem like they work in everything they've been studied. I mean, in HFrEF, HFpEF, CKD, they seem that they are an effective means of, volume removal without maybe the nephrotoxicity of maybe loop diuretics, and there's potentially some added benefits that we don't fully understand. So I would anticipate if, a study would be positive in PH patients, but we'll see. So far, the only study that I've seen that has been negative or neutral was in COVID ARDS. They actually did a study of SGLT2 inhibitors in COVID ARDS, and it was neutral, but otherwise all the studies are positive. So we'll see.
They do have some side effects, but we can monitor those.
The side effects are actually very minimal. I mean, probably a 1%, urinary tract infection. We have not really seen the euglycemic DKA in our heart failure patients. I know the endocrinologists worry about that, but we have not actually seen it, and the cardiology clinical trials haven't really seen a big signal of that. So
sometimes their diuretic properties seem to be fairly remarkable when they're combined with our other diuretics in these.
Yeah, I mean, we usually start them in heart failure. We usually, drop their loop diuretic dose by, 20-25% or something like that. So, they seem like they're very effective.
Yep. Great. Well, thanks again.
Perfect. Yeah. Thank you, Dr. Badesch. That was a great talk. So.
Thank you.